Welcome everyone to the Canadian Nurses Association's webinar series, Progress in Practice. This webinar is about your role in the fight against antimicrobial resistance. This session is being recorded for nurses who are unable to participate today. My name is Elizabeth Marin. I am the Member and Network Specialist at CNA, and I'll be hosting this webinar. At the end of the presentation, we will answer your questions, which you can type in the Q&A box that you can bring up by hovering your mouse at the bottom of your screen and clicking on the Q&A button. We will address as many questions as time allows. The certificate of participation will be emailed to you along with the link to the recording of this webinar. And now a little bit about our presenter, Linda Gergoni. Linda Gergoni is the clinical nurse leader at the Antimicrobial Stewardship Program at the Sinai Health System and University Health Network in Toronto. She is currently working in nursing research and initiatives aimed at engaging nurses in antimicrobial stewardship programs. Over to you now, Linda.
Hello, everyone. Thanks for having me and happy Antibiotic Awareness Week. I'm delighted to discuss with you today the nursing role in Antimicrobial Stewardship Program. I'll start with a quick overview of the objectives. So the objectives of this presentation are to gain knowledge about antimicrobial resistance and antimicrobial stewardship. We'd like you to develop an understanding of the nursing role in antimicrobial stewardship. We will share some examples of successful nurse-driven antimicrobial stewardship interventions, and we will provide at the end of this presentation some tools and resources to support nurses to be stewards in their clinical practice. But let's start with the first question: what is AMR? Next. So AMR, you probably have heard the term AMR or antimicrobial resistance, and AMR occurs when a microorganism, either a bacteria, a virus, or a fungus, evolves and gains resistance to antimicrobials that were previously effective. Antimicrobial resistance is considered to be a huge major threat to our global health. And one thing that I would like to highlight, or maybe kind of dispel a myth, it is important to understand that humans do not become resistant to antibiotics. It's actually the bacteria that becomes resistant to antibiotics. Next slide. So let's talk a little bit about the causes of antimicrobial resistance, and is there anything that we could do to stop it? So if I had to give a short answer, the answer would be no. We cannot stop antimicrobial resistance because it is believed to be an evolutionary process. But what we know from the evidence is that antimicrobial resistance is accelerated by the overuse of antimicrobials in both humans, livestock, and agriculture. And this is an important section in the fight against AMR because we know from evidence that 30 to 40% of antimicrobials used in humans are unnecessary. And from Canadian data, we have a little bit of a higher 30 to 50% of antimicrobials used in humans are unnecessary. Let's go to the next slide and let's talk a little bit more about antimicrobial resistance. So we know we have a problem. However, why should we care? Is this a big problem, or how does this antimicrobial resistance impact us? In 2014, Jim O'Neill provided a review of antimicrobial resistance, and if you note on the left side of this slide, it was estimated in 2014 with a low estimate that 700,000 deaths were attributed to antimicrobial resistance. It was also estimated that by 2050, unless effective actions were taken, antimicrobial resistance will result in 10 million deaths per year with a total cost of $100 trillion US dollars. Obviously, AMR is a huge concern from the healthcare providers, not because of the cost, I mean the $10 trillion, but because it impedes our ability to treat infections that were previously treatable, therefore providing or posing a threat to advances of the modern medicine that we know now. But we know about, I just provided some statistics about the world, but what about Canada? So what does, how does this relate to Canada, and what is the impact of AMR in Canada? Let's go to the next slide. So hot off the press, in November 12, 2019, the Council of Canadian Academies released a financial report titled When Antibiotics Fails that provides a comprehensive report about the impact of AMR in Canada. And something that I want to highlight in this slide, this report has some wonderful infographics, and it's like a very comprehensive report, and I'll strongly recommend for any one of you that have interest in AMR to read it. But something that I want to highlight from this slide is that in 2018, 26% of infections here in Canada are already resistant to antimicrobials that are usually first prescribed to treat infection, and it is estimated that by 2050, this number will raise up to 40% or more. If we're looking at the cost associated with AMR here in Canada, so the overall cost in 2018 was $1.4 billion, and it is estimated that if the resistance rate is at 40%, the overall cost will jump to $7.6 billion a year. When we look at the lives that the deaths that are attributed to AMR in 2018, we had 5,400 lives that were lost per year in Canada as direct result of the AMR. And if predictions are to be true, then in 2050, if the resistance rate is at 40%, we will end up losing 13,700 lives that they will directly be attributed to antimicrobial resistance. So I provided some statistics and some data for the world. I provided some statistics and some data for Canada, and I want you to take a break. And let's go to the next slide. And I want you to think or just reflect for a couple of minutes as to what life without effective antibiotics would look to you. And if you're probably thinking about the data, and if you're probably reflecting, and if I would have to give you a glimpse of my imaginary life, that would mean that many advances of our modern medicine, our chemotherapy, transplantation, or even standard surgeries that we enjoyed in today's year, like a C-section or a hip surgery, they would be considered too dangerous to perform. I will also like to push your imagination a little bit more, and I want to ask you a little bit more about nursing profession. What would nursing profession look like without surgery, without chemotherapy, and without transplantation? You probably are thinking that we will have many of our specialized nursing practices. For example, our ICU nursing practices, our transplant nursing practices, our surgery may vanish. And when you think about the overall impact of AMR, not only worldwide, not only in Canada, but also in our profession, this is a little bit scary. Let's talk a little bit, let's go to the next slide, and let's talk a little bit about the work that Canada has done so far to tackle antimicrobial resistance. So in 2017, the Public Health Agency of Canada released the Pan-Canadian Framework on AMR, recognizing that antimicrobial resistance is a huge public health issue and should not be overlooked. And if you look at the framework highlights 4 pillars as strategies to tackle antimicrobial resistance in Canada. And those pillars are surveillance, infection prevention and control, stewardship, research and innovation. One thing that I want to highlight out of this slide is that if we look in the left side of this slide and we see that antimicrobial stewardship is not a one-person responsibility. Everybody has a responsibility and plays a role in AMR. And you could see that, public, industry, academia, government, it's an effort from everyone. But for the purpose of this presentation, I will only focus on stewardship. I just wanted to touch base with you, and I just wanted to talk a little bit more in the next slide about antimicrobial stewardship programs. Depending on the site that you probably are working, you might have heard about antimicrobial stewardship program, or maybe if you're up to date with the evidence, you probably have heard about antimicrobial stewardship programs. So I just want to talk a little bit about the aim and what are the antimicrobial stewardship programs. So one of the strategies used to address antimicrobial resistance is the establishment of antimicrobial stewardship programs. And these programs usually aim to combat antimicrobial resistance by optimizing antimicrobial therapy. or if I am simplifying this sentence, the aim of these programs is to ensure that antimicrobials are used when needed and only if needed. One thing that I want to highlight out of this slide is the importance of, infection prevention and control programs versus antimicrobial stewardship programs. And sometimes in the clinical areas, those two programs are somehow thought to be the same, and they are not. They work together, they collaborate together, but the aim and the mandate is different. So antimicrobial stewardship program, as I mentioned before, the aim of the program is to optimize antimicrobial therapy, while the mandate of infection and prevention and control as an aid or to help tackle AMR is to conduct surveillance and with aim to prevent and control the transmission of infections. I also want to talk a little bit about the structure of antimicrobial stewardship programs. And these are programs that have been in existence for more than two decades. And usually the structure of this program includes an infectious disease physician, a pharmacist, someone from infection prevention and control, usually an IT specialist or a microbiologist or microbiology lab partner. And, I've somehow put it in red in there, nursing. So nursing has recently captured the attention of antimicrobial stewardship program as key stakeholder and potential contributors in the fight against AMR. And if you actually read and you're up to date with the literature, you probably note that it's about, the nursing literature related to antimicrobial stewardship, it's about 1%. So we have some work to do. And, it's also important to note that these programs are mandated by Accreditation Canada. So I just mentioned, let's look at the next slide. So I just mentioned that antimicrobial stewardship program and nursing is new and is novice to antimicrobial stewardship program. So why now? Why all of a sudden we are looking at nursing as being a participant in this program? So I just want to highlight that we do a lot of nursing practices that align with antimicrobial stewardship. However, there is not a lot of recognition. And if you look at the literature, one of the things that you probably would be able to recognize is that a lot of interventions that they are designed with an antimicrobial stewardship focus, it is very challenging from the workflow perspective to be able to engage nurses in antimicrobial stewardship. However, I think we got a turning point when American Nurses Association released a white paper about the nursing role in antimicrobial stewardship and highlighted some nursing practices that they directly impact antimicrobial stewardship, and they do aid into the fight against antimicrobial resistance. Also this year, in 2019, another turning point was the publication about international antimicrobial stewardship competencies for undergraduate nursing education, because we also have a little bit like a gap in nursing education from the undergraduate perspective. We also have a little bit of, we're a gap into engagement in antimicrobial stewardship activities, even though I just want to highlight and stress out here that there is a lot of nursing activities and practices that we already do that could impact antimicrobial resistance. However, there is not much of recognition. Let's talk a little bit about what are some nursing practices that what is the nursing, this presentation is all about nursing role, and what is some of the nursing practices and how can nurses play a role in antimicrobial stewardship and help in the fight against antimicrobial resistance. So there is quite a few, and you probably can identify even more, but there is quite a few practices that we could impact and we can have a role in antimicrobial stewardship. So one is allergies, one is antibiotic or antimicrobial management, interprofessional discussions, diagnostic stewardship, vaccination, and public education. And I will, explain a little bit more in details about every single practice that I just mentioned. So let's talk about allergies in the next slide, and specifically this is penicillin allergies. This year, some programs or some institutions have made penicillin allergy as a focus for Antibiotic Awareness Week. And what do I mean by penicillin allergy? And if there is anything that I would teach my colleagues out there is to ask the questions, to complete an accurate and to document an accurate penicillin allergy. And what do I mean by asking the question? If there is a patient that during our assessment indicates that he or she is allergic to penicillin, then we need to do a little bit more assessment when it comes to penicillin allergies and ask questions such as, what was the medication? What was the reaction? Did the reaction require any treatment? When did this reaction occur? How long ago? And how far after the antibiotic was given was this reaction? Did this reaction occur? And was there any other antimicrobials that were tried after this reaction? And why is this important, like having a complete assessment, is because we know that 9 out of 10 patients who think they have a penicillin allergies, they don't. And usually 10% of the patient population report to have a penicillin allergies, but we do know that penicillin allergies wane over time, and furthermore, we also know that patients who report the penicillin allergy or are labeled with one are more likely to have a worse hospital outcome. So having a better understanding if this is a true allergic reaction to penicillin or not, it may impact the overall outcome of the patient. Let's talk a little bit in the next slide about antibiotic management. And I also see us as nurses as the last safety point from the moment that the thought about antimicrobial prescribing was initiated, the prescription, and actually the administration. So we're the last safety check prior to our patient receiving the antimicrobial. And a couple of points that I want to highlight about antimicrobial antibiotic management are early and appropriate cultures, and I'll talk a little bit more about this in one of my next slides. It is very important to initiate our antibiotics in a timely fashion, monitoring the adverse event and adjusting antibiotics based on the microbiology report. It's also a nursing role, and we don't have to prescribe. We don't have to, do the changes ourselves, but we could prompt the conversation that we do have some results from the microbiology report. Is there a need for antibiotic adjustment? And also thinking about de-escalation or IV to PO switch from the antibiotics. So sometimes we could prompt the conversation and, inquire if our patient's, the clinical status has changed and our patient could receive a PO an antibiotic. Is there a possibility for us to switch from IV to PO? Also, one of the important things that we usually know and have into our assessment is the antimicrobial resistant patterns of our patients. For example, if we know our patient is VRE positive or MRSA positive, these are pieces of information that they are very important when decisions are made to prescribe antimicrobial therapy. Now I'll talk a little bit more about the overall statement on understanding that just one more day won't do any harm. And this is, usually if you are in any of the clinical settings, you probably have heard that, well, we have decided to have a course of antibiotic therapy for 7 days. We have done all our cultures. Our patient is actually doing clinically better. However, we haven't even seen any sources of infection. We thought there was an infection, but we truly think there wasn't an infection. But we've decided on a 7-day course therapy, and it's just the last day, so one more day won't do any harm. And I want to just, discuss some data on some published research that was published in 2019 about the statement that just one day won't do any harm. So research published in 2019 showed that longer therapy were associated with more adverse event. And in one of the studies that was conducted in 43 hospitals in Michigan with a total of 6,481 GIM patients, they found that 64.8% of the patients had excessive antibiotic therapy, and 49.7% of patients that had excess of antibiotic therapy was done post-discharge. However, they also discovered that the odds of self-reported of adverse event were 5% more per day for any additional antibiotic day. And also another study that was published in 2019 did mention that there was a 4% increased risk of immune resistance for each additional day of antibiotics. And this is one of our roles as nurses, that whenever we hear we're part of the interdisciplinary team, we're part of the conversation, that whenever we hear that one more day, it really doesn't cause any harm, it matters and it does cause harm. Now I just want to talk a little bit about, this is one of my favorite topics, so interprofessional discussions. And if I have to leave complete this presentation with one takeaway point, I would want to say that all members have a role in antimicrobial stewardship, and definitely nurses could play a huge role in antimicrobial stewardship initiatives. So, however, something that is very important from the nursing perspective is that our assessment is very important because we add pieces and data and information to the overall clinical picture of the patient. However, the way we deliver and the way we deliver our assessment impacts the way or influences the way our team makes the decision and thinks about the overall clinical picture of our patients. So from the nursing perspective, it is imperative that we understand the rationale for antibiotic or any antimicrobials use. It is very important that we provide an accurate nursing assessment, and it is very important for us to ask questions to clarify any issues or voice any concerns that we might have related to antibiotic therapy. And I just want to share with you an intervention that, a new practice change and a new nursing intervention that we enrolled in all our critical care settings in our institutions, when we engaged our critical care nurses to talk about, components of infection in a separate entity, in an infection as a system, which was an entity of its own. So this provided a structured place where nurses were reporting any infection findings to the healthcare team members, and this provided also a safe place where they could ask questions about the therapy, or they could voice any concerns about antibiotic therapy. I just want to touch base a little bit about diagnostic stewardship, and if there is one thing about diagnostic stewardship that you could take away from this slide is ask the question, should I collect it or not? And I'll talk a little bit more about the urine cultures and the blood cultures. So one of the things that I want to stress out of the diagnostic stewardship is always collect your cultures based on best practice guidelines and collect them appropriately. One of the other important aspects of culture collection is to ensure when and if it is possible and safe to do so, to collect the appropriate cultures prior to antibiotic therapy. So as I said, I'll talk a little bit more about urine cultures because this is a nursing, it concerns nursing. And I'll talk a little bit more about asymptomatic bacteriuria versus the urinary tract infection and blood cultures. And I'll give a couple of highlights about blood cultures and understanding the blood cultures a little bit more. So let's look at the next slide and let's talk about asymptomatic bacteriuria versus urinary tract infection. So it is always a challenge in the clinical setting when we have a microbiology report that indicates there is bacterial growth from the urine culture. And it's always a challenge to distinguish between asymptomatic bacteriuria versus urinary tract infection. And this sometimes leads to, that over-treatment of asymptomatic bacteriuria. So I'll give a couple of pointers as when we think about diagnostic stewardship. So if we have a patient that has a Foley catheter in for more or equal than 30 days, 100% of the times you will have bacteriuria. Also, it is very important from the nursing perspective, generations ago, we were trained that if there is a foul-smelling dark urine, we automatically collect the urine cultures because we believe this is associated with urinary tract infection, and this is not the case. So foul-smelling dark urine does not equal infection. And having a positive urinalysis without any signs and symptoms of infections does not really equalize urinary tract infection. And I'm going back to two myths here again. One is better safe than sorry. So the idea that, well, we have a positive urine culture, we're not quite sure if it's asymptomatic bacterial or urinary tract infection. However, it's better to treat than to be sorry. And I'm going back to, the previous slide that antibiotics are not benign. And we now have at least 6 trials that they do demonstrate that, treatment of asymptomatic bacteriuria does not have any benefits to the patient. And if anything, there is harmful effects from treating patients with asymptomatic bacteriuria. And the other myth from the nursing perspective that we've heard in the clinical setting is that there is no harm in collecting urine cultures. And we want to just, talk a little bit about the ripple effect of, collecting a urine culture inappropriately means that collecting a urine culture with not proper, signs and symptoms of urinary tract infection leads to identification or discovering of asymptomatic bacteriuria, and then, you get into that, decision-making process. This is asymptomatic bacterial or urinary tract infection that ends up in treatment or over-treatment of asymptomatic bacteriuria. And I just want to share with you another research or another nursing-led intervention that we did in our institution aimed to reduce unnecessary urine cultures. So I'm just going to talk a little bit about the results, and if you have any questions about, the methodology, or you want to talk a little bit more about this, feel free to email me. So we wanted we knew that nurses play a huge role in urine culture collection, and we wanted to design a study that answered 2 questions. Nursing, we wanted to prove that nursing could be, a huge focus in reducing unnecessary urine cultures. But if, we are designing an intervention, we wanted to know what was the best way to do it. So probably most of you would, agree with the fact that when we look at nursing intervention, we do a lot of education and we do a lot of knowledge translation interventions, as an intervention. However, when we did a research study that combined different interventions. So we had 4 different units with 4 different interventions, and the result, or the unit that performed better and sent the most appropriate urine culture, was the unit that received education about signs and symptoms of urinary tract infection, when to collect urine cultures. We did audit and feedback, a little bit new to nursing. Happy to discuss with you if anyone had a question as to how was this done. And we also did a workplace redesign combined with visual cues. So when we had multiple interventions in place, we saw that that particular unit sent 93% of that urine cultures appropriately. Another thing that I wanted to point out of the slide, out of the data on the left side of my slide, is that if we're doing only education as an intervention and no intervention at all, there is very little behavior change. So if you see, it's like 69% versus 65% of appropriateness of sending urine cultures appropriate. I'm just going to talk a little bit in the next slide about the blood cultures. So just going to give a couple of pointers about the blood cultures and the fact that sometimes in the clinical settings we hear about, well, we have our patient on antimicrobial therapy, and again, it depends a little bit on the case scenario, but the blood culture are not, we're going to have to wait until the final blood culture result comes positive, and then we'll make a decision when to discontinue the antibiotic therapy. So I just wanted to kind of share a couple of pointers from the blood cultures. So usually by 72 hours, by 72 hours, more than 95% of the blood cultures that could grow something would have already grown. So, and usually only 4% to 7% of all culture sets usually grow something, and 50% of the blood cultures are false positives. And this is where, from the nursing perspective, there is something we can do to impact this number, because if we, follow best practice guidelines, we could lower this false positivity number. I thought I wanted to talk in the next slide a little bit about the infection management timeline, and this is mostly for acute care setting, or you could, as to how are the decisions made when we actually send the microbiology report on how is antimicrobial therapy changed and, and modified for us to get to a target therapy for the patient. And I just picked up a urinary tract infection. It doesn't have to be, it could be any infection. So if we have a patient with a lower abdominal pain, with flank pain, urgency, pain with urination, and the patient is febrile, and we're thinking that this patient has a urinary tract infection, has an infection, most likely our prescribers will start empiric therapy and will ask for urine cultures and sensitivity to be sent. Once this urine culture, and hopefully then again, I'll stress out the importance of, collecting this urine culture when possible and safely to do so prior to starting the antibiotic therapy. When this urine culture is sent to the microbiology lab, within 3 hours, we usually get the gram stain report. And this report has some very important pieces of information for the clinicians because it usually provides us with an idea if, if the bacteria that's growing is gram positive or gram negative. It provides the shape of the bacteria, and it also gives a little bit of information about the quality of the sample. If we're thinking within 24 to 48 hours, we usually get a partial microbiology report, and this is when we usually get our pathogen or our bacteria identified, so we have a name of the bacteria. And if there is a discordance between the empiric therapy and the bacteria that was identified, this is a possibility for us to prompt the conversation as nurses and to ask if we need to change the antimicrobials. We don't need to know the answers, but we can definitely prompt the conversations. And within 72 hours or more, we usually get the final microbiology report, and this is when we have the susceptibility for the particular pathogen. And again, this is when we can do another double check to ensure that there is if there isn't a discordance between the prior therapy and the susceptibilities, and if there is a change that needs to happen for the overall therapy. I'll talk a little bit next about, immunization, and maybe remind you, it is the flu season, and have you taken your flu shot yet? So the immunization and the vaccination in general is viewed as an aid in tackling AMR because it goes back to the old saying, an ounce of prevention is worth a pound of cure. And it is seen that vaccination reduces not only the incidence of sensitive and resistant infection, but as a result, it will reduce the appropriate and inappropriate use of antimicrobials. And the overall, one of the aims to tackle antimicrobial resistance is to ensure that antimicrobials are appropriately used and used only if needed. And then I will talk a little bit in the next slide about our role as nursing in education. And we're not talking only patients' education. I'm going to spread this up, and I'm just going to talk a little bit more about public education. So we do know from the evidence that our patients and the public have huge gaps related to understanding what is antimicrobial resistance and even understanding their own antimicrobial therapy that they are on. And we also know, and if there is a way to target antimicrobial resistance, we know that our patients are key contributors, and they need to be partners with us in the fight against antimicrobial resistance. And this should be one of the goals of one of strategies to address antimicrobial resistance. We want our patients to be stewards because that will be much easier for us to be able to tackle this issue that we have with antimicrobial resistance. But for our patients to be stewards, they need to be knowledgeable and they need to know and be aware about antimicrobial resistance. So we did a study that we completed this summer in our institution, and I'm just going to highlight a couple of points of this study. Again, if you have any questions, I'm more than happy for you to email me and I can discuss a little bit more. But one of the things that we discovered again from our study, which is similar to the existing evidence, gaps in antimicrobial, gaps in patients' knowledge related to antimicrobial resistance, gaps in our patients' understanding the antimicrobial therapy. But something that was very interesting to me from the nursing perspective was that our patients come to our clinical settings with expectations, and one of the expectations was that they want the healthcare providers to be experts in antimicrobial therapy or antibiotic therapy. They also want us to provide education. They want to know why are they prescribed an antibiotic, and they also want to be engaged in the decision making that we as healthcare providers are making related to antibiotic therapy. So I just want to highlight in the left side of this slide, like we asked our patient, this was where I was a little bit surprised. So we asked our patient, who would you be most comfortable approaching with questions about your antibiotic treatment plan while you are in the hospital? And I truly thought that nurses would trump this and we would be the ones. However, as you can see from this graph, that we came third and the nurse practitioners came fourth, and the doctors trumped this question. So, I mean, this is a little bit of a lost opportunity from a nursing perspective. We could really educate and we could really provide that information that the patients are requesting because we have that knowledge. I am going to close this presentation with some nursing resources in the next slide. So I would strongly recommend that you will, if you're looking for some tools or resources, to take a look at our website. So www.antimicrobialstewardship.com. If you have an interest into nursing practices or you want to, do an intervention in your clinical area, American Nurses Association Redefining the Antibiotic Stewardship team has some recommendations about nursing practices and the role of registered nurse in the hospital antibiotic stewardship practices. Also, I'll also like to, point out a couple of papers that talk about, the multidisciplinary approach. So David Hall and all talks about how can we engage nursing at the bedside to be stewards in their clinical settings. And if you're really interested in education, I think the paper from Courtney et al., Development of Consensus-Based International Antibiotic Stewardship Competencies for Undergraduate Nursing Education would be a nice place to start. And if you want to know more about the report, the Canadian report that was released on November 12, 2019, when antibiotic fails, I have provided the website. And if you have, if you want to know more about antibiotic allergies, I know AMR Canada will release interesting infographics and more information about penicillin allergies. I will close this presentation with a little bit of an acknowledgement. I'd like to thank my team here at Sinai Health System and University Health Network for supporting the nursing role in antimicrobial stewardship, and also for looking at the slides and giving feedback as to what should we talk and discuss today.
Thank you, Linda, for your presentation. Before we move on to the Q&A period, we'd like the participants to answer a few short poll questions, and these should be showing up on your screen right now. So we'll move on to the Q&A period while you're answering the poll questions. You can write your question in the text box in the Q&A button or window when you click on the button. So one of the first questions that we've received, Linda, is someone would like you to go over the steps again for the penicillin allergy assessment that you spoke of at the beginning of the presentation. They didn't get all 4 steps clear in their mind, so they'd like you to go over that again if you could.
Yes, so there is actually more than 4, it's about 7 steps, but I will go over the questions that you need to ask when you're doing a complete penicillin allergy assessment. But all these questions are also available in our website, so you don't have to write everything down. But questions that you should be asking once a patient has indicated that he or she is allergic to penicillin is you most likely want to know what was the medication, so is it penicillin or another medication? What was the reaction that the patient experienced? Did the reaction require any treatment? Because if this allergy occurred, let's say 15 years ago, and the patient needs to be hospitalized, then you will have a better understanding of what the allergy was all about. When the timing is imperative, because again, if it's 30 years ago, we do know that penicillin allergy wanes over time. And again, how long after the antibiotic was given? Was it an immediate reaction, or was it a reaction that occurred like an hour or 2 hours or maybe days after the antimicrobial was prescribed? And have you ever tried other similar antibiotics and did you react to it? So is this only penicillin, or there's other antibiotics that you reacted to it? And once you have this complete documentation, this provides the clinician with a better understanding as to what was the status of this allergy, and it gives them a little bit of a better guidance, is that should they really go with the first line of therapy, or indeed this patient is truly allergic, or should they go and do more of like penicillin allergies or challenges to be able to prescribe the most appropriate antimicrobial.
Thank you, Linda. So another question that we received is, in your experience, have you noticed a difference in regular urine collection versus midstream urine collection in relation to the antibiotic treatment?
So we don't have any data about regular versus midstream, so I would not be able to know. Like I don't know if any evidence that actually have seen or have looked at this. But it's one of the things that we really obviously the practices is definitely important. I mean, collecting urine cultures using best practice baseline is very important. But one of the most important aspects is that when you collect that urine culture, you must ensure it's done appropriately. And what I mean by that is ensure that you have signs and symptoms of urinary tract infection, and not like, if you have a foul smelling urine or if you have a dark colored urine without any other symptoms, because you might, and this is not done intentionally. Sometimes we think we're advocating for the patients and it's better for us to know, but you might get that report that if there is a positive urine culture without signs and symptoms of urinary tract infection, which that's actually not symptomatic bacteriuria, and really asymptomatic bacteria. Now we do have evidence should not be treated except in specific, solid organ transplant, in kidney transplant patient population and pregnancy. But, the other patient populations, we do have 6 papers that they talk about the importance of not treating it.
Thank you, Linda. So another question is, if one more day leads to an increased risk of harm, how does that impact the long-standing mantra of completing the course of antibiotics as prescribed?
Oh, this is an amazing question. So this is a little bit challenging because, we don't have evidence in the sense that, usually whenever you have a prescription that you go to your physician, one of the things and one of the directions that is given to you either by the physicians or the pharmacist is to complete, the whole course of antimicrobial therapy. However, and it's very challenging to control that, right? Because you can't have these patients go, and it's dependent on the infection. So you cannot have these patients, to go home with a prescription and, for them to be able to, if it's like an empiric and a urine culture was collected, for example, in the doctor's office, it's very challenging for for the patients to be able to make those decisions. And this is like, is there any evidence that supports that you have to complete it, for all the symptoms, for all the infections? Not that I know of, but there is specific, some infections that you have to complete, the course of therapy. So this is why it's imperative that you talk to your healthcare professionals so they could guide you as to when you should complete it or your course. But it's an overall, kind of an idea that when you go to your doctor's office and when you go to your pharmacist and you fill up your prescription, one thing that you're told is to complete the therapy. However, we will know more, because one of the things that one of the trials that they're going on right now, it's, if anyone has heard, it's the new 10 is the new 7 and the new 5 is the new 3. So there's trials right now that they're looking into shorter courses of therapy. So if there was a 10 course of an antimicrobial therapy for 5 days, there are trials that they're looking at if there is any difference if we do for 3. However, it's a bit of challenging to be able to answer this question. You're right, you're completely right, that we do know, we have evidence that, extended, especially when it's inappropriate, extended antibiotic therapies do cause, there is a problem. However, it's very challenging to address this issue right now, unless this patient is in your clinical setting and it's under observations, and then you could prompt as nurse a conversation and you could discontinue because you have more control. But in outpatient clinics and, when in a primary care, it's a bit more challenging to address unless you have shorter, we have evidence that shorter antimicrobial courses are just as effective as longer. So basically the new 5, the old 5 is the new 3, and the old 14 is the new 7. So we'll know more once we have some more results.
Thank you, Linda. Another question. As my setting does not involve an RN as part of the interdisciplinary role, what would you suggest to get started in this antimicrobial stewardship program?
Sorry, can you repeat that question? I didn't hear it.
Sorry, as my setting does not involve an RN as part of the interdisciplinary roles, what would you suggest to get started?
So it depends, so there is a couple of ideas that I gave here in this presentation, and if I could have had a little bit of a better understanding in, when you're in the setting, and you could send me an email, I could give you some suggestions, but, starting with knowing why are you prescribing these antimicrobials or antibiotics would most likely give you a little bit of a guidance as to where the gaps are, or maybe even doing a little gap analysis in your clinical setting that would support. You need to know your territory, you need to know your clinical setting to see which intervention would be more appropriate. And whoever asked this question, please send me an email and we could discuss a little bit farther. I just need to understand the setting a little bit better so I could give some ideas as to where can you start.
Okay, great. Another question, is the data in the presentation from an adult population, or does it consider neonatal population? And would any practices be different for a neonatal patient?
Yeah, so most of the data, so some of the data is from adult population. So all the nurse-led interventions that I mentioned are based on an adult population. And when we're looking at the neonatal, I don't think anything should change in the aspects of when we look into allergies, when we look into understanding why we prescribe antimicrobials, the cultures that we send. So the intervention could be, kind of targeted a little bit different, but the overall idea should remain the same, giving those antimicrobials appropriately even to the neonatal patient population.
Okay, great. So another question, should antibiotics become restricted drugs for prescribers?
This is a good question. This is an amazing question. And it's a bit tricky because if you're up to date with the evidence, one of the strategies for addressing AMR and actually ensuring that our antibiotics are effective is to restrict certain antimicrobials or certain antibiotics, which, or maybe to have an ID consult, and the ID physician would be the only one to be able to prescribe a certain antibiotic. However, one of the things that we see from evidence is that when you look into the intervention, or when you target your intervention to be on restriction, so you restrict the specific antibiotics, one thing that we notice, or you would see in the data, is a phenomenon also called squeezing of the balloon, which means that you restrict one antimicrobial or one antibiotic, but what ends up happening, the clinicians overuse another. So really, this defeats the purpose of you, of us, I should say, as healthcare professionals, to minimize. The target should always be behavior change. So it should always be ensuring that antimicrobials are prescribed appropriately. So doing, audit and feedback, educating, coaching the healthcare professionals to support them so that that antimicrobials are appropriately prescribed. I mean, as I said previously, yes, you could restrict, but is the restriction the best possible strategy? No. Is it the easier, maybe, and the quicker? Probably. But if you really want, change that sticks, you want the behavior change. So you want, the healthcare professionals to be trained and to know when to prescribe antimicrobials and to prescribe them appropriately.
Oh, thank you, Linda. So another question, do you monitor appropriate surgical antibiotic prophylaxis and address inappropriate use?
Oh, this is great. So our program has recently started, probably a year and a half ago, if I'm not mistaken, a new intervention, NAP. So it's a National Antimicrobial Prescribing survey where we actually conduct audits in our institutions, and we get data from our hospitals, and we get an idea about antimicrobial prescription, pre-op prophylaxis, and we are in the process right now of collecting the data. And once we do have an idea, at least for our institution, and our Andrew Morris is working with to have the same surveys, and they have about 50 other hospitals that are participating in the NAPS, or National Antimicrobial Prescribing Survey, that will indicate, because whoever asked this question, this is a brilliant question, we cannot start working unless we have data and unless we actually know specifically where the problem is. So once you have this audits or the surveys completed, that will, kind of target, and they will give you a better understanding as to where should you start your work. What I mean by this is, an issue, is this a prophylaxis? Is this, a GIM service that needs a little bit support into antimicrobial prescribing? So we have the data, and there is work that's being done in our program to address areas when, there is opportunities there for improvement.
Great. So another question, what successful strategies can you recommend nurses to use to approach prescribers about over-prescribing antibiotics, especially with the elderly population?
Ask the question. And one of the things that, from working with a nursing group for a while now, asking the question, it's imperative, and asking the question in a knowledgeable way, it's just as imperative. So if you're actually asking the question, should I really collect this urine culture, is one thing. If you're asking the question a little bit more triggered, should I collect this urine culture because this patient does not have any urinary tract infection? And I do know from the evidence that, you most likely will discover an asymptomatic bacteriuria that will be treated and might cause harm. So I think this is, asking a question with evidence will, be a question that will stick a little bit more than just, having the short, should I really collect it?
Okay. One more question. What is the vaccine for UTI available today, and is it covered by Medicare?
A vaccine for UTI?
Yeah.
I don't think there is any vaccines that I know of, and I might be corrected here, for urinary tract infection.
Okay. So with regards to diagnostic aids, would you be able to comment on any of the point of care tests that your institution uses and their clinical utility and practice?
So for the diagnostics, from the diagnostics perspective, we base, urinary like urine cultures, blood cultures, MP swabs. There is a lot of diagnostic tests that we do in our institution. We're a large institution. However, one of the things from the nursing perspective that I want to highlight is that when we send this diagnostic test, it is imperative that we send them appropriately, and not just because, and not just in case, or not just to make sure. You know, they need to be like, it's a diagnostic stewardship, so we should always, you know, send them with appropriate rationale. And I'm not saying that when they're not sent inappropriately, they're intentionally done, by all means not, but I think that we could be a little bit more patient advocates to say that, you know, is it really needed, because indeed it could cause harm.
Okay, so that's all the questions that we have for now. So thank you again, Linda, for your presentation. And her email address and Aiden Hamza's email address is on the screen if you have any questions further after this webinar for either of these nurses. We hope this session stimulated your thinking about your role in fighting antimicrobial resistance. You can access our recordings of all these webinars that we present every month by visiting CNA's YouTube channel. And if you haven't already done so, please consider registering for the next webinar, Community Health Nursing Vision, Roles and Capacities for Transforming Health Systems, which will be held on Tuesday, November 26th from 12 to 1 p.m. Eastern Time. We hope you have a great day, and thank you for participating today.